Imagine a healthy, active adult who bends over for a routine task, only to feel their lumbar spine abruptly seizing up. The surrounding muscles lock into a rigid, protective spasm. In clinical terms, this is acute low back pain, a condition strictly defined by symptoms lasting anywhere from a few days up to 4 weeks. It is a nearly universal human experience. Research suggests that approximately 85 By bypassing the search for a concrete anatomical cause, the current workflow may inadvertently overlook targeted treatments and allow a manageable episode to progress toward a chronic state. The WFNS committee established a global mandate to standardize care, producing evidence-based guidelines for clinical diagnosis, radiological triage, and long-term prevention. This Prisma chart details the filter used to build these recommendations. Thousands of clinical studies were screened, focusing specifically on the last 10 years of diagnostic research. A separate parallel review evaluated over 3,300 records to establish the most current understanding of the epidemiology and etiology of back pain across different cultures. To translate this data into a working protocol, the committee used the Delphi method. This involved multiple rounds of anonymous voting by international experts to reach a consensus on the most effective care pathways. These resulting standards are not based on regional habits. They are the result of a massive, global synthesis of evidence designed to triage acute low back pain in any socioeconomic environment. Clinical triage begins by isolating the 10 to 15% of cases with red flag indicators. These represent patients who require immediate surgical evaluation for serious conditions like malignancies or neurological deficits. For the remaining majority, the WFNS protocol operates on a single principle. The origin of the pain is identifiable and should be clinically isolated. The lumbar spine is composed of functional spinal units. Each unit contains distinct structures with the capacity to generate localized pain signals. Discogenic pain originates within the degenerated intervertebral disc. It is often characterized by a patient history of severe episodic pain. Facet joint pain is caused by degenerative changes in the joints connecting the vertebrae. A key diagnostic feature is that this pain is not worsened by coughing or the Valsalva maneuver. The sacroiliac joint is another progressive generator that must be differentiated from other lumbar structures. Finally, myofascial pain is driven by microinjuries in the lumbar fascia. These injuries lead to local ischemia and a lower pH, triggering a release of inflammatory mediators. Because these pain generators require different management strategies, a precise clinical diagnosis is the only way to select the optimal treatment for the patient. In many clinical settings, the immediate reflex is to order an MRI. The goal is usually to reassure the patient that their spine is structurally sound. The WFNS guidelines state the opposite. In the absence of red flags, routine radiological imaging is actually contraindicated for acute low back pain. High-resolution imaging often reveals findings that are entirely asymptomatic. In most adults, bulging discs or bone spurs are simply signs of normal aging, not necessarily the cause of the patient's current pain. Disclosing these incidental findings to a patient can actually trigger a nocebo effect, where the information itself leads to a worse outcome. The patient begins to view their back as broken or fragile. This perception leads to fear avoidance behaviors and a dangerous reduction in physical activity. This anxiety drives nociplastic amplification, where the nervous system becomes hypervigilant. The pain is no longer sustained by tissue damage, but by a cycle of fear that transforms the ache into chronic low back pain. In reality, the natural history of most acute back pain is a spontaneous resolution within weeks, provided the patient remains active. By withholding unnecessary imaging, the clinician protects the patient from the psychological feedback loop that can turn a temporary mechanical problem into a permanent condition. The failure to triage this condition correctly at the acute stage has significant macroeconomic consequences. In fact, there is a notable and fascinating epidemiological paradox. Acute back pain is reported much more frequently in high-income nations than in lower-income regions, despite the prevalence of manual labor in the latter. Researchers suspect this is driven by aging populations, higher rates of obesity, and increasingly sedentary lifestyles in developed countries. The direct medical costs are staggering. In Spain alone, the annual cost of consultations, tests, and surgeries for back pain reaches 8.9 billion euros. But the direct costs are just the beginning. Indirect costs, including the social burden of the disease, are estimated to be 75% higher than the direct medical expenditures. This table summarizes the WFN's consensus statements. Statement 4 acknowledges that specific risk factors for the initial onset of acute pain remain highly variable. However, Statement 5 emphasizes that once pain occurs, the transition to a chronic state can be actively intercepted. The committee found moderate quality evidence that immediate, structured exercise is the most effective way to prevent acute pain from becoming chronic. When this exercise is paired with patient education, specifically regarding the non-threatening nature of most spinal findings, the risk reduction becomes even more significant. The optimized workflow for acute care is now clear. It moves from a targeted anatomical diagnosis directly into an active protocol of exercise and education. Clinicians are encouraged to move away from the non-specific label in favor of identifying the specific structural generator. At the same time, withholding imaging in the absence of red flags is a critical step in protecting the patient's psychological recovery. By combining an anatomical diagnosis with early movement and education, clinicians become the barrier that stops a temporary ache from turning into a lifelong condition.